her little morning snack, I'll go ahead and go over a few announcements. My name is Lisa Bowie, go by she, her, hers. This is the Quality Health Outcomes Committee meeting known as QHOC. Just a few Zoom technology tips, mute, unmute. Please reminder to keep your phone on mute unless you're speaking. If you'd like, keep your video on so we can see everyone's lovely faces. There's the raise hand function button, which is under the reactions button down at the bottom or on the top if you're using the iPad. There's also the yes, no's if we're doing a poll, and or you can use the chat function to message us. Michelle, please make sure we have chat on so that everyone can chat. Everyone, I can't remember if that's a setting that we regularly have on or not.
It's on.
Thank you. For those that are speaking, Michelle is here to help us throughout the meeting. Jennifer is off today, so if you have any questions, please message Michelle or myself, and that's Michelle Hatfield. Next slide. The morning agendas, and we've got Pharmacy and Therapeutics with Roger Citron first up. Then we go into the HERC update, and then EPSDT with Dawn and a few others. Then we'll have a short 5-minute stretch break, etc. to do what you need for yourself. And then, oh, I think we're starting the Learning Collaborative at 11 o'clock. It shouldn't say 11:10, so just a 5-minute stretch break. So the Learning Collaborative will begin at 11, I believe. So I think that's correct. And then we'll go into lunch and then have the quality performance improvement session in the afternoon. Next slide. So I'm just going to go over a couple quick announcements and then I'll turn it over to Dawn or Jeannie if they have any announcements. So you all might be wondering, hey, where's the 2023 QHOC series? I have created the Zoom I guess the links, etc. for 2023. So I'll be sending those out. What I'll also be sending out is the, I guess you could call it the list, the who's on the list. If you want an Outlook appointment, we keep a really long list, and then we keep what we call, I guess you call it the member list of the 4 names. So I'll be sending that out to the CCOs that are on the points of contacts. So there's one point of contact for medical, behavioral health, oral health, and quality. And then I'll say, here's the list of everybody that's on the Outlook list. Let me know if that's who you still want. Because sometimes I don't even have names, I just have email addresses, because it's like, Lisa, please add this person to the Outlook list. And I'll copy your respective innovator agent. So I'll be sending that email out, like I said, here shortly. And then what will happen is you all get a short period of time, literally probably like just a couple weeks. And then you reply back and you say, yes, this person's still with the organization, or no, please take this person off the list. And then I'll send the whole 2023 series of Outlook appointments with all the Zoom appointments out. As a reminder, external individuals, so i.e. anybody that's outside, whether that's through a CCO or through a partner organization, you get the full 10:05 or 10 o'clock to 3 o'clock appointment series. Internal individuals, you'll get your separate email from me saying, do you want to be on the QHOC appointment stream still? So I'll send out separate emails for CCOs and then for internal. Those will be coming out, again, copy to your innovator agents this week. So look for those. If you don't get one and you're on this public meeting and you're like, hey, I didn't get the email, ask your partner person and say, did you get the email? Oh yeah, I got the email. That means you're not on my list. And you should probably email me. And that can be found on the QHOC website. And say, Lisa, I didn't get the email. Someone else in my organization did. That means you're not on the QHOC list. And if you want the Outlook appointment, then email me and we can add you. So that's the first thing. The 2023 series email will be coming out this week. The other discussion is I talked with the QHOC chairs And we talked about the December meeting. So in December, we'll have the HERC update, and we'll have an EPSDT update, because again, EPSDT, there's some changes coming for January. So there'll be an EPSDT update and there'll be a HERC update. And then the rest of December meeting will be, I don't know, Doug, I can't remember what we call it. We'll kind of call it somewhat like a retreat. I don't know, we're gonna call it a 2023 planning session. You can call it whatever you want, but we're gonna call it planning. And what we're gonna do is we're going to go into some breakout rooms, and we're going to talk about, we'll have some key questions, and we're going to talk about the 2023 planning for QHOC. So we'll have some key prompts. We'll mix and mingle you all, and we're going to talk about some planning of what we want for this meeting structure. And we'll talk about learning collaboratives. We'll talk about meeting goals, meeting participation, etc. So you can talk with your QHOC chairs of anything that you'd like to put in those prompts, but I've already talked about it with Doug, Laura. Jeannie happened to miss that particular session, and so the December meeting is on. We'll have EPSDT, the HERC, and 2023 planning. Any questions before I turn it over to Dawn or Jeannie? Okay, then, Dawn, Jeannie, do you have any updates?
I do not, ma'am.
And I want to say good morning, everybody. This fall time brings on a lot of turbulence as we anticipate changes for January 1, and at the same time as having many places to be, it also feels like we're hungry for communication. So QHOC is not going to suffice for all that. Obviously, there are a variety of venues, but please do feel free to reach out for communications when the issue at hand is one that needs to be addressed in a timely fashion. I forgot to introduce myself. Dawn Mautner, she, her, a white woman, long dark hair, and Medicaid medical director for the state of Oregon at the Oregon Health Authority, and I appreciate your participation here. A couple more issues have been brought to my attention that I don't have the chance to address today, but I want you to know that they have been brought to my attention so that we can look into them for future QHOC, if not addressed in tweens and communications. The substance use disorder gap report, system gap report entitled Oregon Substance Use Disorder Services Inventory and Gap Analysis came out at the end of September. And it has been brought to my attention that that discussing it here has been requested, and so no, we can't do that today, but it's certainly something that we can look at for the future. Process for changing CCOs, we certainly can discuss. Air transport and a barrier being the companies can't get a DMAP number. This has gotten a lot of attention, so we'll get the right folks in the room to bring you up to speed. There's a fairly massive, comprehensive non-emergency medical transport, but also medical transport of all types effort right now. And I'll turn it over to pharmacy. Thanks for being here.
Good morning. Can you hear me okay? Good morning. Roger Citron, director of the Drug Use Research and Management Program. He, him, white male, gray hair, grizzled gray beard coming in. We last held a P&T committee meeting on October 6th. The recommendations were put forward to Director Allen and approved by the OHA and posted on October 12th, providing a link here so you can go and see those recommendations. You can also access a recording of the meeting and see the minutes. Next slide. So I'll go through the different items that we reviewed at the committee meeting. We looked at the targeted immune modulators. We presented a DERP summary. We're a member of the Drug Effectiveness Review Project out of OHSU. Based on the clinical information, we made no changes to the PDMP We did modify the TIMS for autoimmune conditions criteria. We updated the indications for risankizumab, baricitinib, and ustekinumab. We looked at the comparative cost and executive session, and there was nothing compelling us to make any changes to the PDMP. The link I have here is to our searchable web application, and it's the dedicated criteria for the TIMS criteria. Next slide. We also looked at the colony stimulating factor literature scan based on the clinical information. Again, recurring theme, no changes were recommended to the preferred drug list. We looked at the cost and executive session, and we made the recommendation to make Granix non-preferred on the PDL. The link here will actually take you again to the searchable web app, and this will show you the class for the CSF. So it shows you all the agents, preferred, non-preferred status, and all of the documents that we've presented to P&T over the years. Next slide. We presented an anti-epileptic class update and new drug evaluation. Based on that evaluation, we recommended designating ganaxolone as voluntary non-preferred. It is a carve-out medication, so it can't be made non-preferred. It is voluntary. And we put in a safety edit to restrict its use to its FDA-approved indication and to have the appropriate dose. Based on some of the newer agents, we changed the name of the class to the outpatient anti-epileptics. There's a new formulation of midazolam that's coming out. It's an auto-injector formulation. We've seen it approved by the FDA, but I haven't seen it hit FDB yet, so don't think it's on the market quite yet. We did again look at pricing in executive session, and we recommended making Nasolam and Valtoco. These are the midazolam nasal spray and diazepam nasal sprays, making both of those preferred on the PDMP. So there's options in addition to the Diastat rectal gel. You might see that there's been some shortages recently, so something you might want to consider in your own benefit. Next slide. We did a multiple sclerosis class update. Again, no changes based on the clinical information. We consolidated the injectable MS criteria. We amended the oral multiple sclerosis PA criteria to remove any required step therapy. We looked at costs again in executive session and recommended making Plegridy preferred on the PDL. Next slide. We looked at the HIV class and did a literature scan. We really haven't touched this class, but based upon current utilization, actually no utilization in several years, and guidance and some of the side effect profiles, we recommended designating stavudine, didanosine, sequinavir, and nelfanavir as non-preferred on the PDL. Again, they're no longer recommended in current guidelines, and to reiterate, there is no recent utilization. Next slide. We reviewed the GLP-1 receptor agonists and SGLT2 inhibitors. There's a new class of drug that was came to market, so we included that in with the PA criteria. Those are glucose-dependent insulinotropic polypeptides, or GIP therapies. So we updated the GLP receptor agonist PA criteria to remove the concomitant prandial insulin restriction. Recommended maintaining the SGLT inhibitor PA criteria. There was some consideration removing it, but the committee felt strongly that they wanted to keep the criteria in place. And they did add requiring annual evaluation of renal function. Recommended maintaining tirzepatide as non-preferred on the PDL and subjecting it to the GIP PA criteria. We looked at comparative cost in executive session, and we're not compelled to recommend any changes to the PDL. Next slide. Dupilumab, as you're probably all aware, is just a drug that keeps getting new indications, so we keep reviewing it. Recommendation was to update the PA criteria to approve treatment for eosinophilic esophagitis in patients 12 years of age and older who weigh at least 40 kilograms, to allow appropriate step therapy for PPIs in patients with eosinophilic esophagitis, and to approve treatment for moderate to severe atopic dermatitis for those patients that weren't adequately controlled on topical therapies, or for younger kids that are 6 months of age or older, where those were not advisable. Next slide. We presented an ADHD literature scan and drug use evaluation. Again, no PDL changes were recommended based on the clinical information. We did revise the PA criteria because to reflect the maximum age and dose limits that's supported by compendium were changes some of the product labeling. We excluded patients initiated on the, so when certain of the agents have an age limit, for example, of 18, the recommendation was to not exclude them cut from coverage once they exceed that maximum agent. So for example, Capve and Tuniv, I think they don't exceed past 18, but if they've already been approved that therapy, the recommendation was to let them stay on that. After comparative cost in exec session, we recommended making Qelbree preferred on the PDL. Next slide. Presented lumateperone drug use evaluation. Based upon the information, there was a recommendation to consider outreach to providers in regions with higher use of the agent to identify the reasons for their practice differences. Again, provider education seemed like the tool that we could bring to bear on this to raise awareness of the similar outcomes and higher costs with this agent, but no other utilization controls were recommended or warranted this time. Next slide. We noticed some use with Anavera. It's a once an annual product, but we'd seen some, I guess, overuse or over early refills. So we recommended implementing a 300-day minimum supply for point of sale prescriptions that would require a pharmacy to enter an override if they need to have an early refill, that if it's less than 300 days than the previous prescription, and then we wouldn't allow more than 2 refills in a 12-month period. And again, that's just to make sure for appropriate use that the agent is used annually. Next slide. Next P&T meeting is coming up on December 1st. We have posted the agenda and all the final materials back on the 1st of this month, and you can find those here in the link to our website. Next slide. I'm a broken record here. We're still looking for 2 physicians, either MDs or DOs, actively practicing in Oregon, who might be interested in waving at windmills with us, joining the fray for the P&T committee. They can ask me any questions they have. Again, we meet every other month in the afternoons from 1 until 5 o'clock. And it's 3-year appointments. We don't look for any specialties, just people that appreciate evidence-based medicine and might be interested in helping recommendations that go to the OHA for consideration. And with that, I'll entertain any questions if there are any.
Any questions for Roger? Either raise your hand through the reactions button or in the chat.
Yeah, this is Jeannie. I just wanted to say thank you for addressing the beard. I think it's perfectly timely since we are getting into Christmas and many folks celebrate Santa. So I think it's nice and timely. So no worries.
Thank you. I won't shave it yet. All right, appreciate the opportunity. Thank you, everybody.
Take care, Roger. And I think we're turning it right over to Ariel. Welcome, Ariel.
Good morning, everyone. My name's Ariel Smits. I am the Medical Director for the Health Evidence Review Commission, and I'm going to give you the HERC update today. And we have our fancy new slide, so hopefully this will work okay. Our usual first slide about new, well, it was COVID, now it's sort of public health, but this is all about COVID. There's a new CPT code for the booster for Novavax that just came out. And also doing our review of new codes, there are a couple of HCPT codes I wanted to bring to your attention in case you haven't seen them yet. There's the G0310 to G0315 series. As a primary care doctor, these are awesome. They're counseling for vaccines that aren't administered. So currently the vaccine counseling codes are tied to the actual administration of the vaccine. These can be billed if someone talks about risks and benefits of COVID vaccination or something, but the patient declines. Or, for example, if you're talking to a family about an alternative vaccine schedule and you are counseling on multiple vaccines, but they're going to space them out and just come in for nurse visits. So these codes should be open. They are new this year, but CMS is changing how they're doing HCPCs. They're rolling them out quarterly instead of doing a once a year kind of open them all. So these codes came out a few months ago. There's also a new K code for home COVID tests. This, according to HSD folks, this was opened a while ago, and you all should be covering it. These are the COVID tests that you get from the pharmacy that someone can take home. Next slide, please. So since our last presentation in October, we've had multiple advisory panel meetings. Our behavioral health advisory panel met. They looked at the 2023 CPT codes related to behavioral health. There's a caregiver training code. So this is for parents or caregivers. And it was added to 4 lines, the 2 that relate to autism, the ADHD line, and the conduct disorder line. If there is any interest from your providers to having it covered for other diagnoses, please forward that to me. These are the only ones that we found evidence for. There was also a remote therapeutic monitoring for cognitive behavioral therapy devices. This was excluded, as we're excluding all remote therapeutic monitoring currently. Oh, sorry, go back one. And then they had a HCPT codes about skill training. It's a per diem code. We currently pay for the whatever hourly or something like that. So it was added to all the behavioral health lines. Next slide. We also looked at perpetrator services. These are services for people who have done abuse of some type, so child abuse, intimate partner violence, or have had sexual related abuse types of issues. These are interesting codes because there's not a lot of evidence that they actually are effective. And in fact, for intimate partner violence, treatment actually seems to increase the violence. So we are, this actually has changed, I think, even since this slide was made. We are keeping, there is a code that's currently for perpetrators of child abuse. We're keeping that on the abuse line because there are CDC recognized programs that can help with that. We are opening a code for perpetrators of essentially sexual violence. And this was just for the diagnostic list. This was based on provider input that these patients should have at least one visit with a therapist to look for other treatable conditions like ADHD or depression or something, even if we don't have a lot of good evidence that the actual treatment of the condition is helpful. And then the other 2 codes, the one for intimate partner violence and another sort of non-specific perpetrator code, are going to stay excluded for now. And then we also looked at intentional self-harm. These are either diagnostic or on the poisoning line, and we decided to leave them there. These aren't specific to depression or suicidality or something that needs to be further investigated. Next slide, please. Our genetics advisory panel also met. We looked at the 2023 CPT codes that relate to genetics. We did our usual update of our NCCN guideline references. We also looked at molecular pathology procedure codes. These are updated large panel tests for cancer. They were remaining diagnostic. We looked at cytochrome P450, made it diagnostic, and included it in the current guideline about P450 testing. The inherited bone marrow failure syndromes were made diagnostic. TPMT, which is an enzyme that is involved in drug metabolism. There's both an enzyme activity testing and a gene test. These were both made diagnostic. And then we looked at the very large cancer gene panels and made diagnostic. This is just the 3 sort of standard big panel codes. And we are going to have hopefully a specific cancer genetic work group that we are putting together to kind of help us further look into what should be covered for gene panels, how many genes, what type of testing. There's some proprietary tests like Foundation 1, where do they fit in, etc. So if you have anyone who is a cancer oncologist, cancer pathologist, etc., who might be interested in joining this group, please let me know. And then we added coverage for Decipher prostate because of new NCCN guidelines. This is a test for prostate cancer tissue. Next slide, please. Anyone have any questions before I dive into VBBS about GAP or BHAP? But also I'm happy to take questions at the end. All right, so our next VBBS and HERC meetings are November 17th. These are online meetings. You are all welcome. They're open meetings. You're welcome to attend and just monitor. If you do want to make any remarks or presentations, you need to sign up very soon online. We have our usual consent agenda, which is just simple code changes. We have items discussed with leadership and no changes recommended. This includes non-coverage of kyphoplasty, non-coverage of neurofeedback for various conditions, and then also non-coverage of pneumatic compression devices for lymphedema as the general sort of PT type of therapy for lymphedema is just as effective. If any of you have any input on these devices for your patients who might not have easy access to sort of the standard human being PT, please let me know. That's our one kind of open question about whether there is decent access to lymphedema decompressive therapy, or whether the compression devices might be something that might be useful for populations with limited access. So let me know if that's an issue for your CCO. We are going to discuss corneal collagen cross-linking, which is a treatment for keratoconus, which is a thinning of the cornea. The recommendation is to add coverage. Next slide, please. And then we have our 2023 CPT codes. There were fewer codes than usual, although they were still kind of a lot to go into. There's about 40 straightforward codes that are either sort of routine replacement codes or codes that had very similar codes or things that just seemed very straightforward. We then looked at absorbable mesh or absorbable prostheses for delayed wound closure. This appears to be controversial, and there may actually be an increased infection risk if you do absorbable mesh versus non-absorbable. So we are recommending non-coverage. Radio frequency repair of nasal valve collapse is experimental, so we're recommending non-coverage. Gastric balloons we currently don't cover, but this is a new code for them, so we're adding them to our guideline note 173 to explicitly state that we don't cover them. Hepatitis B surface antigen quantitative test, we found evidence that this is used for monitoring of treatment of hepatitis B, not for diagnosis. So we are putting this on the hepatitis line and not the diagnostic list. I wish I could say that we're adding coverage for an RSV vaccine. I would really like one, especially with the major surge around the country. However, there currently isn't an RSV vaccine that has FDA approval. So we are excluding this code, and we hope that there will be an approved vaccine. There's 2 or 3 that are currently in late stage clinical trials. If any of them get FDA approval, we will have HSD move them to a covered line, a covered list before we, and then we'll add them at the next prioritized list to the covered vaccine line. Orthoptic training. This is training for eye movement issues. We're going to put it with a very similar code, and we have a guideline regarding that we'll just update. Quantitative pupillometry is a test to see basically what you would, this is one of my favorite nice reviews was, looking at the different cost effectiveness. This is a test to see if someone's pupils are not moving to judge brain death. I liked their cost effectiveness. This is like a multi-$100 device versus using a pen light that you could just use by hand. So we are not covering this. Next slide. There's some HCPT codes that are, in addition to the ones I already mentioned, the vaccine counseling codes and the COVID home testing I mentioned earlier. There's also some codes for doula services that we are adding to the pregnancy line. There already is a program to cover doula services. This just adds additional codes for doulas to use. Currently, they're using a modifier for the regular delivery code. This will be their own code. Hydrocele repair in adults, we currently limit coverage to those up to age 18. We are adding limited coverage for adults with a guideline that somewhat like the hernia guideline would require pain and limitation in function. Eosinophilic esophagitis is an allergic, allergy-related inflammation of the esophagus. We had moved it 5 or 6 years ago off of the line that had long-term PPI therapy, because at that point, the standard of care was not to treat with PPIs. In the intervening years, they have completely changed the treatment recommendations, and they now are recommending double dose long-term PPIs. So we're moving it back to the line with long-term PPI therapy guidelines. Our human growth hormone guideline, we are substantially rewriting it or getting rid of it. There's 2 options on the table. This is because there are multiple indications for use in both children and adults that we currently don't allow coverage for. For example, if an adult has had pituitary surgery and has hypopituitarism or something. So we are substantially updating our guideline. Botulinum toxin for strabismus, we currently cover this. We're just doing some housekeeping changes to clarify coverage. Next slide. We are looking at acupuncture. Again, we've updated things since this slide went out. The recommendation is to discuss whether or not to add to the fibromyalgia line. There's some evidence for some marginally clinically beneficial short-term benefits. And so we'll discuss if that's worth the use for, and this would still remain a non-covered line. And then we're also just clarifying a couple of things in the guideline. We are going to add IUD placement for endometrial cancer. This is not standard of care, but it is an acceptable alternative for people who can't undergo surgery or radiation because of comorbidities, and also for women who wish to maintain fertility, although that's a very limited use that NCCN has very strict coverage of. So there'll be some, this will be available for people as a option when they can't do the standard options. Cochlear implants, we are going to update our guideline. There have been expert recommendations, and CMS have changed their coverage. It's very technical about how you judge whether someone has adequate hearing, what score they need on certain tests. And also the recommendation now is for it's much more liberal for very small children. They can have a little bit less hearing loss if you have documentation that they are not progressing adequately with acquiring language, etc. We are looking at our PET scan guideline, and based on new NCCN recommendations, we're adding some coverage for small cell lung cancer, neuroendocrine tumors, multiple myeloma, and then we're expanding our thyroid cancer coverage from the limited coverage that we have currently. Those are the only cancers that we found NCCN's recommending PET scan as a treatment decision point. We are then looking at CPAP. We are going to add to our sleep testing guideline when repeat sleep studies would be covered. And it's mainly if there's been a significant clinical change, for example, a significant weight loss or a surgery or something since the last sleep study. And then one thing I know that is of great interest to this group is the definition of, it's actually not apneic, it's hypopneic event, which goes into your apnea score. So how much do you have to desaturate before you can consider it an event, whether it has to be a desaturation of 3% or 4%. It seems like a really minute detail, but actually ends up making a very big difference in the number of people who would qualify for CPAP. We didn't find any evidence that using the less restrictive, the 3% cutoff, actually results in improved outcomes. The people who got CPAP solely with that more lenient guideline, based on one RCT, had very minimal clinically significant improvement in anything. So we are specifying in our guideline that you need to use the more stringent 4% or CMS criteria. Next slide. So that was VBBS. Obviously, those are all the staff recommendations. We will update you when we have, when the meeting occurs and all of the final decisions are made. The Health Evidence Review Commission, in addition, is going to be discussing quality adjusted life years, or QALYs. There were a couple of policy options that went out for public comment, and the public comments were all consistently that we need to basically further engage with the disabilities community about this, and staff is planning on doing that. Next slide, please. The Evidence-Based Guidelines Subcommittee will be meeting in January. And they are continuing to work on continuous blood glucose monitoring, bariatric surgery. The biomarkers for cancer may end up going only to the work group, or it may end up as a coverage guidance, depending on what the work group that I mentioned earlier recommends. And then they're looking at chronic disease self-management programs. And we're always interested in any other topics that might be of interest to you all. Next slide. So as usual, you feel free to email the herc.info mailbox. We will always get that and send it to the appropriate person if you have any questions. Also, our specific emails are listed below if you have any specific questions or just want to contact us. Anyone have any questions for me? Sorry that was kind of a blitz through a very busy fall. Hopefully, if you have any questions, you know where to get in touch with me, or I'm happy to answer them now. Doug, I see your hand up.
Hey, Ariel, thank you. There was a lot to cover there. I was thinking about your RSV vaccine decision and trying to sort of think about how that's going to play out with EPSDT changes that we're all considering. I anticipate we'll get some requests for that, and providers will claim that it's medically necessary. How do you have the evidence available, or would we have available your assessment on that we could review if and when we get some requests?
Yeah, so there is no approved RSV vaccine.
Right, but I can assure you we're going to get requests for them, and there will be kids, right? And so
no, actually the vaccines are for adults. They're mostly for older adults, the ones that I have seen that have actually made it to the later stage clinical trials, which is not the group that I would be hopeful for. Pfizer did a study on pregnant women to see if it would provide protection, vaccinate the mom to provide protection for the baby. And that never made it to the final, it was like stage 2 or 3, and then they stopped pursuing that. So I'm assuming it didn't work. I haven't seen any that are any vaccine that's being tested right now in toddlers or babies, which is where I think the major impact would be. But as it is, we as a state don't cover vaccines that don't have FDA approval, is my understanding. I think we did cover meningococcal B vaccine, which I believe had FDA approval, but not CDC recommendation, although I might be misremembering that. So currently, I don't know of any candidate vaccines that would be available for children.
Okay, good. Well, then I'll withdraw the question related to EPSDT. It doesn't sound like it'll be an issue unless we, the window of sort of very young adults, potentially we might get some requests, but we can deal with those.
Yeah, and I'm not sure how much it'll be used for older adults. I mean, I know that is a group that is hospitalized with RSV at times, but it's not the huge group that would be, if there was a workable infant RSV vaccine, I think it would just become a standard vaccine that we would give everybody.
Right.
And the reason we're excluding it is that if a new vaccine is approved and gets CDC recommendation, we would then move it to line 3. But it would be in this sort of like ancillary list or whatever until we could do that, so that it would be available. But there is a presentation, I believe, that the CDC is giving in the next month or so about all of the vaccine candidates. So if you're interested, I saw a link to that going around on some CDC, like, share sites. So I'm sure if you went to the CDC, you might be able to look it up.
Great, thank you.
Other questions?
Hey, this is Jeannie. It looks like there's a question in the chat about, is the upcoming CGM discussion for members with type 2 diabetes?
Yes, it's looking, so we currently cover CGM for type 1. So this would be looking at type 2 and gestational, and looking at various severities. The one piece of this that I would love input from you all is there are people who are not the classic type 1, which is an autoimmune disease, but they don't have islet cell function. So there is a different diagnosis called other diabetes mellitus, and it includes things like having had your pancreas entirely removed, which would make you type 1, I would think, but it doesn't, it's not type 1 because it's not autoimmune. Kids with CF who lose pancreatic function, those types of things. We're kind of trying to figure out where they fit in this discussion. We're still working internally a little bit on that. And then I was going to reach out to some endocrinologists. My fear is that if we start looking into that, it's going to end up being anybody who's insulin dependent, because how can you, at what point do you say somebody doesn't have any working islet cells? So it's actually a weird space. There is type 1 and type 2, and then there's this in-between type, which may or may not be a type 2. Sorry if that's really unclear, but
no, Ariel, this is Jeannie. I actually have somebody really in the middle of that right now, and I was wondering if it was going to be covered or not. So that's really actually quite helpful. And I'm also just wondering about kids. I apologize, I'm not up to date on the CGM monitor coverage for kids. If they are not type 1, if they are somewhere in the middle, like a 10 to 12-year-old who's, 1, not fully been diagnosed, or 2, is somewhere in the middle as well, maybe has some function left, but not fully non-functioning.
That's exactly where we are struggling right now. So like a 12-year-old who has more classic type 2 because of obesity or whatever, maybe they're on steroids for a long time for their asthma or something, they probably shouldn't get CGM. But a kiddo who has CF, perhaps, where they have mostly lost islet cell function, where do they fall? I mean, at this point, it's going to be individualized review on your part. But we are definitely going to need to get into that space and define something.
Well, and there's also a recommendation around kids for checking their sugars so frequently when you're really trying to get them started, and then maybe using, because I mean, I don't know any kid who wants to poke their finger frequently. I don't know any adult, frankly, that wants to poke their finger frequently. So, trying to get somebody under a control, and then really knowing what their blood sugar is on a regular basis with kids. It seems to me a lot of the peds endos are saying with most kids, regardless of type, to try and use the CGM just for, it's easier for them and you get better data. So not sure if that's something you all have addressed.
I don't think we have specifically looked at like children versus adults, but like I said, we're definitely looking into this interspace where people may have, and it could be children or adults who may not have, if an adult has had multiple bouts of pancreatitis, how much actual pancreatic function do they have? And how do we, I don't know, maybe I'm just showing my age. We used to do a C-peptide to see if they actually were making insulin. I don't know if that's even done anymore. Maybe I'm just old. So yes, we're definitely struggling in that space. other questions, either raise your hand or put them in the chat.
Ariel, one last question. How's the email change going? Are you still getting emails to old lists or directly to you, or are we all kind of switching over and using this HERC info email now?
I both. I have been getting some specifically to me, and then we get a lot to herc.info. There's no wrong way to get in touch with us. If you mail it directly to me and it actually needs to go to Jason, for example, I will forward it for you.
Thank you.
Yeah, and thank you for the reminder, Jeannie. Our personal emails at some point are going to migrate to the new oha.oregon.gov. I don't know when, but we will let you know, and there'll be a grace period after it happens where the old email will still work. All right, I will update you again in December about any and all decisions that are actually made.
Thank you, Ariel. And as Lisa is off on covering another call, I will slip in and facilitate the transition to my own talk here briefly. There was one update that I forgot this morning, which is about doula reimbursement to $1,500. That had been proposed long ago. We've been talking about it for a long time, and it has been finally approved by CMS to modify the state plan. So retroactive to July 1, there is that increase in doula reimbursement, which the information has already been shared about that and about how it has come to be over the course of essentially this whole calendar year in conversation, and happy to field questions about that. But now we'll transition into EPSDT, everybody's favorite. Here are the updates for early and periodic screening, diagnostic, and treatment benefit, which provides now comprehensive and preventive healthcare services for children under age 21 who are enrolled in Medicaid, the Oregon Health Plan. That is to say, EPSDT constitutes the child and youth benefit within the Oregon Health Plan. Next slide, please. So what has happened, as many of you are aware, is that there was a waiver that included the EPSDT requirements in terms of the prioritized list. That waiver is no longer going to be in effect as of January 1, when our new waiver takes effect. So formerly known as unfunded, there are services that must be covered, all services that are medically necessary and medically appropriate for children and youth under the age of 21 who are enrolled in OHP. Those include services that may have been below the line on the prioritized list and may still be below the line on the prioritized list, or they may have been moved above the line because that is ongoing work. Services that don't pair also need to be covered if they are in fact medically necessary and medically appropriate, and if they are named as non-covered ancillary services, but they are medically necessary and medically appropriate for the case in front of you, they also need to be approved. Next slide, please. The HERC, under the guidance of Ariel and her team, the Health Evidence Review Commission, is completing a review of all of the services below the line, unfunded services in our Oregon parlance, with the unique needs of children and youth in mind. Most remaining services that qualify as APSDT are being moved above the funding line. And for those services that do remain unfunded or in the unfunded region of the prioritized list, EPSDT requires that medical necessity and appropriateness, or dental necessity and appropriateness in the case of a dental service, be determined on a case-by-case basis for children and youth. I want to acknowledge Jason Gingrich's note in the chat that says that review is officially complete as of the October meeting, and those changes will be effective January 1, 2023. Jason, if you'd like to jump in and say anything more about that, I welcome you.
No, that's all. Thank you, Don.
You bet. So guidance is being finalized. A draft guidance document for CCOs was provided in September. That we did get some feedback. We have been working to bring that into the guidance. We are incorporating it and addressing in the final guidance document will be posted and disseminated in advance of the CCO contracts and compliance work group meeting on November 22nd. The guidance for providers, separate from CCO guidance, is being finalized and will be posted and disseminated in early December with the hope of supporting implementation in January. Next slide, please. Here is the sequence of communications that has been happening and continues to happen with different parts of the CCO administrations. And as is often the case, communications within CCOs, much like communications within OHA, are not necessarily happening in real time in the way that the information is changing. So we encourage all of you and your teams to maintain proactive open dialogue about this, so that what might change by the CCO contracts and compliance meeting on November 22nd will be communicated back around to medical directors if it's different from what I say today. I don't think there's going to be anything different from what I say today, because we've worked very hard to stabilize those questions before today. But those open communications within CCOs as well as within OHA have offered some stumbling blocks in the past. The final guidance document will be provided in advance of that November 22nd meeting. Next slide, please. So the updated requirements apply to items that remain in that unfunded region of the prioritized list. As we mentioned before, below the line, non-pairing, and quote, non-covered ancillary services, no longer non-covered for children and youth. These requirements apply regardless of whether the CCO is using a pre-service review, that would be prior authorization, or a post-service review, that would be claims review process. Anything medically appropriate and medically necessary. OHA must also abide by these requirements for our fee-for-service OHP members. We will make mistakes. We know we won't get everything right at first, and we know that it's challenging to operationalize. It's a lot. We're in it with you. We're trying hard to get it done in advance and anticipate problems up front, but this is dialogue. The more you tell us in real time, the faster we'll be able to respond and provide you with the structure and guidance to really stabilize. It does require significant systems changes at OHA and in each CCO. OHA aims to implement these changes with minimal disruption and to identify and address areas for improvement as needed. As I said, the dialogue with you in operationalization is a key feature of that. Oh, okay. All right, updates to CCO guidance. The CCOs must conduct an individual review for medical necessity and medical appropriateness, or dental, as the case may be, prior to denial of the service or claim. This includes auto denials. So CCOs cannot deny a service or claim solely because it is below the line, non-pairing, or a quote, non-covered ancillary service. This includes automatic denial by claims processing systems. CCOs can deny a service or a claim if, upon review of clinical documentation, it is not medically necessary and medically appropriate or dentally appropriate for a dental service for the individual child or youth. CCOs can deny a claim if it is incomplete, contains errors, or for other technical reasons, like it doesn't have all the information that's needed, or there is intrinsically conflicting information that administratively doesn't identify the proper member, for example. So those kinds of denials are not subject to individual medical or clinical review, but auto denial for reasons related to the prioritized list is not going to be tolerated. Next slide, please. So the pathway to implementation, these requirements are effective January 1, 2023, and that was the result of a rather extensive negotiation with CMS. The full implementation is expected by the end of Q1 2023. Compliance will be monitored through the quarterly exhibit NOABD sample evaluation beginning with the Q2 submissions, but it is expected that it will already be getting operationalized in Q1. And we know that there's a great deal of future work and quality improvements, quality and process improvement that is going to bring our mass save systems into alignment and be sure that kids are getting all of the services that are medically necessary and medically appropriate. They do have to be both medically necessary and medically appropriate. Today, as you can tell, today we are focusing on the areas that are being updated from the draft guidance provided in September, based on the feedback and questions and decisions since we issued that draft. Next slide. Okay, so the pathway to implementation. While a CCO's claims processing systems are being updated, the following guidelines apply. Utilization controls can still be used, but any established limits on services, like number of visits for a particular service, must be considered tentative pending an individual review, again, for medical necessity and appropriateness. All needed services must be covered regardless of those preset limits. So if there is a child who needs more than a standard limited number, they need to be able to access those, and the process that you and we are putting into place needs to provide that pathway. So the final denial decisions must be based on that case-by-case review. Next slide, please. There is an EPSDT webpage where you can access all the documents that are available, and we'll be getting that updated. Next slide. For any questions, please do email here. Dialogue with collaborators and partners, including families and members, help us center equity. We're not on the ground and you are. We need this ongoing dialogue to do the best job of serving Oregon's communities and those kids who need services. Happy to take any questions now, also through that email. Is there one more slide? Yeah, there are the regulations. Any more slides? How about some resources? Thank you for your attention.
Thanks, Dawn. why don't we take a 5-minute break? So it looks like that we are going to start the Learning Collaborative at 11:10 after all, so that we can have a stretch break. Thank you for the, oh,
Lisa,
sorry, Jeannie.
sorry, but Dr. Rajani has a question, I think, about the EPSDT. He raised his
Okay.
hand. Could we take that real quick?
Yes, and then just Learning Collaborative speakers, thank you for coming on time, but we are running a little behind. So Dr. Rajani, go ahead and ask, Bhavesh, go ahead and ask your question. Then we'll take a short stretch break and try and start the Learning Collaborative at 11:10. Bhavesh, go ahead.
Okay, thank you. So the question is based on some thoughts that we were mulling over in terms of personnel and the workload that this may create, and in terms of who is required to do the determination of appropriateness and necessity. Does it have to be a physician, or can it be any of our clinicians that do this type of work to support, our utilization reviews?
I don't know the answer to that, Bhavesh. It's a good question. My first response is, if it's going to be an approval, it can be anyone. If it's going to be a denial, it may require the level of a medical director, a physician, but that is speculative. So let me make sure and check in with our teams to see what direction we can offer. Let's document that question and we'll get it back to you. And we're trying to minimize those requirements by getting all those services above the line as best we can. And David, it applies to all services in this age group, not just those identified through the EPSDT process. It's all kids all people who are going to be eligible for EPSDT, so they can't be faced with the denials of the services that we intend to cover. Happy to take any more questions through the chat. Please enjoy your break, and we'll get back to you with the answers to the ones that I can't take in real time and answer today. Thank you.
Did you see the one in the chat, Don? From David Shute. Maybe we could just take that one off. Sorry, maybe you addressed it. Apologies.
She did address it.
Okay, thank you.
Okay, so Don will follow up with Bhavesh's answer, and then let's get back at 11:15. Thank you so much for the speakers who have joined. Everyone can take a quick stretch break. Take care of yourself. Be back at 11:15, and we'll